Hello, my name is Kayleigh Fitzpatrick, and I'm going to discuss obesity in the United States. Obesity is often discussed as an individual issue, a matter of diet, exercise, or personal responsibility. But in reality, obesity is a complex public health crisis shaped by policy decisions, healthcare access, economic inequality, and even social media influence. In this presentation, I will examine how the Affordable Care Act has influenced access to obesity-related care, how public health systems track and measure obesity outcomes, how recent legal challenges threaten preventative services, and how social media and big pharma marketing are shaping public perception of weight management. By looking at obesity through the lens of health policy and quality of care, we can better gauge whether current systems are truly supporting patients and better recognize any gaps that create inequities for patients in better need of care. Today, I'm going to begin by discussing the health policy at the center of this issue, the Affordable Care Act. The Affordable Care Act, or ACA, was enacted in 2010 under President Obama. Its primary goal was to expand access to health insurance and improve the overall quality of care in the United States. One of its most important features was expanding Medicaid eligibility, although not all states chose to participate in that expansion. This graphic on the right provides further information explaining how the ACA improves quality of care, which will be discussed in greater detail later on. For individuals with obesity, the ACA made several major improvements. Before the law, insurers could deny coverage due to pre-existing conditions like type 2 diabetes or hypertension, both of which are closely related to obesity. The ACA eliminated that practice, meaning individuals with obesity-related chronic illnesses cannot legally be denied coverage. Additionally, the ACA established 10 essential health benefits. These include prescription drug coverage, preventative services, and chronic disease management, all of which are crucial for people managing obesity. The law also mandates that preventative services such as diabetes screenings, blood pressure checks, and behavioral counseling must be covered without cost sharing, which means that insurers must cover 100% of these costs. However, there are still setbacks. Medicaid expansion was left to the states, and some states chose not to expand coverage. Furthermore, obesity is sometimes still viewed as a lifestyle or cosmetic condition rather than a chronic disease, which creates barriers to coverage for treatments like bariatric surgery or GLP-1 medications unless other medical conditions are also present. So overall, the ACA significantly improved access and quality of care for patients with obesity, but gaps still remain when it comes to quality of care. Next, I want to explain how obesity is tracked and measured in the United States, because data collection is essential to evaluating quality of care. One major system is the National Health and Nutrition Examination Survey, or NHANES. This program is conducted by the CDC and collects data from about 5,000 randomly selected participants each year. What makes NHANES specifically valuable is that it gathers measured health data, not just self-reported information. Participants complete interviews and then visit mobile examination centers where professionals measure BMI, conduct lab testing, and perform health assessments. Because the data is measured directly, it provides highly reliable statistics that inform both state and federal policy. It allows policymakers to determine whether obesity prevention programs are actually improving measurable health outcomes. Another important system is the Behavioral Risk Factor Surveillance System, or the BRFSS. This is the largest health survey system in the world, conducting over 400,000 phone interviews annually. Unlike the NHANES, the BRFSS collects self-reported data on BMI, physical activity, nutrition habits, and the use of preventative services. While it does not track individual readmission rates, it plays a crucial role in identifying behavioral risk trends and access to care at the state and local levels. Together, these systems help evaluate whether preventative services and quality improvements under the ACA are making a real tangible difference. Now I'd like to discuss a real-world legal challenge that directly impacts obesity prevention services. Kennedy versus Braidwood Management Incorporated. This case challenged the ACA's requirement that private insurers must cover preventative services without cost sharing when those services are recommended by the U.S. Preventative Services Task Force. So why does this matter for obesity? Because preventative services like obesity screening, dietary counseling, and cardiovascular risk assessments are included in these recommendations. If insurers were no longer required to cover them at no cost, patients could face high copays, and research shows that even small costs discourage people from seeking preventative care. This is especially significant given current statistics. Over 42% of American adults have obesity, and nearly 1 in 5 children are affected as well. Many individuals with obesity live in low-income or marginalized communities, where financial barriers already limit access to care. Since the ACA's implementation, preventative services have been available without cost sharing, and studies have shown improvements in health outcomes. For example, behavioral interventions aimed at reducing cardiovascular risk factors have been associated with a 20% reduction in cardiovascular events. So this case represents more than just a legal debate. It directly impacts whether preventative obesity care remains accessible and equitable to patients. Finally, I want to address the impact of social media and pharmaceutical marketing on public perceptions of obesity treatment, particularly surrounding GLP-1 medications like Ozempic and Wegovy. Social media has led many consumers to believe that semaglutide GLP-1s such as Ozempic and Wegovy are a solve-all cure to obesity. These drug companies, which have taken prominence on social media and other networking platforms, often don't tell the truth regarding how these drugs work, alongside any negative side effects these drugs may cause. Semaglutide drugs only work to suppress appetite, meaning they do not directly cause weight loss, and only work in combination with reduced caloric intake and better health habits. There has also been a mass avoidance on the topic of several GI issues that have stemmed from using these drugs. And a key point to note is that pharmaceutical companies at the end of the day are businesses. Their main goal is to advertise their drug as a product, regardless of how it truly improves health outcomes. On platforms like TikTok, these medications are often portrayed as miracle solutions for weight loss. One creator even claimed that GLP-1 injections erased her feelings of hunger for an entire day. However, this representation can be misleading and can create a false image of how these drugs truly work. GLP-1 medications work by mimicking a hormone that increases feelings of fullness and slows the stomach's emptying. They suppress appetite, but they do not independently burn fat. Weight loss occurs when the medication is combined with reduced caloric intake and lifestyle changes. Additionally, side effects such as nausea, vomiting, dehydration, and GI issues are often underrepresented in advertisements. Some researchers have referred to these drugs as commercial determinants of health, as corporate interests tend to shape health behaviors and outcomes. There is also a misconception that insurance should universally cover these medications for weight loss. Originally GLP-1 drugs were developed for diabetes management. Many insurance plans do not cover them if they are prescribed solely for weight loss without other qualifying chronic conditions. Social media has had an immeasurable influence on forming people's opinions. This information posted on social media can go viral regardless of whether it is true, which commonly leads to misinformation spreading. Social media, as a big instigator of propaganda, opens up the need for balanced health communication that accurately represents the benefits and risks of weight loss drugs. The inconsistency of social media creates the need for stricter regulatory guidelines to ensure transparency and prevent exaggerated claims from going viral. Additionally, public health campaigns should educate consumers on comprehensive weight management, which includes balancing medication with additional lifestyle changes. As I show my cited references and AI user statement, I'd like to close with this. The key takeaway is that while GLP-1 medications can be effective tools, they are not cure-alls. Obesity is a complex chronic condition that requires comprehensive care, including behavioral therapy, preventive services, and systemic policy support, not just pharmaceutical solutions. Ultimately, improving obesity outcomes requires more than medication. It requires sustained policy protections, equitable insurance coverage, evidence-based preventive services, and honest public education. If we want to improve the quality of care for individuals with obesity, we must treat it as the chronic, multifaceted condition that it is, and ensure our health policies reflect that reality for American consumers. Thank you.